Okay, now I'd like to talk about mefloquine. That action and use is true. It kills the erythrocytic forms of P. vivax and P. falciparum. So mefloquine can be used to kill the erythrocytic form of P. vivax and P. falciparum. MOA has not been fully established, but it is assumed that it works just like chloroquine. It is also the drug of choice for malaria in regions where chloroquine resistance for P. vivax and P. falciparum is found. It can be used for chloroquine resistant malaria. Resistant mefloquine may develop quickly, so it's also used to treat acute attacks, although neuropsychiatric effects makes it a second choice agent. PHK, well absorbed after oral administration, it undergoes hepatic metabolism via the CYP3A4, followed by excretion in bile and feces. It has a prolonged half-life of 1 to 4 weeks, so it stays in the body for a long time. Adverse effects, they are dose-related, so at low doses, used for prophylaxis, reactions are generally mild, nausea, dizziness, and syncope, but at higher doses, used for acute treatment, there may be GI disturbances, nightmares, altered vision, headache, etc. Mefloquine can prolong QT interval, like other drugs that we mentioned, like quinidine and quinine, might prolong QT interval. Then it may also pose a risk of severe cardiac dysrhythmias in patients, so should be avoided in patients with dysrhythmias or QT prolongation. Toxicity to the CNS is a concern. It causes vertigo, confusion, psychosis, and convulsions. The incidence of this neuropsychiatric effect is about 1 in 13,000 for prophylaxis. So for prophylaxis, the neuropsychiatric effect is about 1 in 13,000, but it declines to 1 in 250 when used for acute therapy. High dose should be avoided by people with epilepsy or psychiatric disorders. Drugs should be discontinued in patients that develop psychiatric symptoms like hallucination, depression, suicidal ideation, and they should contact their prescriber for a substitute quinine. So what we said is that mefloquine has neuropsychiatric symptoms that may not allow it to be prescribed, like quinine or quinidine. Drug interaction, ketoconazole, which is a strong inhibitor of CYP3A4, can increase its levels. We said CYP3A4 will metabolize mefloquine, and ketoconazole would inhibit CYP3A4. That means once given together with ketoconazole, the availability of the drug probability will remain so high. So they shouldn't be administered together or within 15 days of stopping mefloquine. So meaning within 2 weeks of stopping mefloquine, the patient should not receive ketoconazole because of it has a longer half-life of between 1 to 4 weeks. Rifampin is a strong inducer of CYP3A4, so rifampin can reduce the therapeutic dose, the therapeutic dose that's available for mefloquine. So therapeutic failure can result, so increased dose may be required. So whereas ketoconazole would increase the viability of this drug mefloquine, a drug like rifampin, which is an inducer of CYP3A4, will reduce the availability of the drug in the body. Preparation dose and nutrition is available as a 250 mg tablet. For prophylaxis, adult dose is 250 mg once a week. Pediatric dose should be 3 to 5 mg per kg once a week. Drug should be given 1 week prior to traveling to an endemic area and should continue for 4 weeks after leaving the endemic area. The adult dose for acute treatment of P. falciparum or P. vivax is 750 mg, that is 3 tablets initially, followed by 500 mg, taken 6 to 12 hours later. The pediatric dose is 15 mg per kg initially, followed by 10 mg per kg, taken 6 to 12 hours later, and that's when we stop. Thank you.